Hi, everybody. I'd like to introduce myself. I'm Wendy Keach. I'm the Executive Director of Health Translation SA, and I'd like to welcome you here and hope you've had a lovely lunch. Before we move into the event to spring into clinical trials, I want to just acknowledge that we're meeting on the land of the Kaurna people and acknowledge that they're traditional custodians of the Adelaide region. We recognise the Kaurna people's cultural, spiritual, physical and emotional connection to their land. We honour and pay respects to Kaurna elders, both past and present, and all generations of Kaurna people now and into the future. And I appreciate that there is a bunch of people online, I think. Do we have a number of those? Yep, lots of people online. So I'd like to acknowledge the lands that you're all on, wherever that may be. And I know we have had people from across Australia who've signed into this event, so really pleased with that. So I'd like to just start before we jump into the body of it, but just acknowledging HTSA is about collaboration, about bringing people together, being a catalyst and a broker to actually, get things happening and be able to stimulate things to happen across South Australia and in some cases nationally. I'd like to acknowledge that today is a collaboration between SA Health, the Australian Teletrials Program, SAHMRI Clinical Trials Platform, ARDC, and NCRIS funding, who support the HSANDA project, which HTSA runs on behalf of South Australia. So this is a collaborative effort to bring people together, to get you guys see a lot of things on one attempt. So that's really the essence of why we're here today. Some of you may recall a successful event we convened again, the same collaboration last year. And we had, again, a lot of people in the room and a lot of people online. So we were really pleased when everyone came together a few months ago and said, let's do it again. It was good. It was fun. And we know the community appreciated it. So to that end, we have a program for you, which I think will be of interest. It obviously has pulled in a lot of people wanting to come. And it really covers off a whole range of areas. Firstly, we're going to have someone speak, and I'll introduce Professor Stephen McDonald in a moment. We're then going to have some interesting presentations from the emerging clinical trials in regional South Australia that are associated with the Teletrials program. We'll then move to some more information about the Teletrials program, but particularly training opportunities that are coming out of that, but also things that are available for everybody, whether you're involved in Teletrials or not. And Renee will actually speak to that. We'll also then move to hear a bit about clinical trials at SAHMRI and have Emma Heath, who's recently stepped into the role of leading the platform at SAHMRI, to tell us about what they're doing, followed by Natalie, who's going to talk about HSANDA and where that's up to, and that's come a long way in the last 12 months as well. And then our wrap-up will be the wonderful Karen Best, who's going to talk about clinical trials, applying them in the community. So hopefully that will give you a smorgasbord of information that will really be something that you can take away with you and enjoy and then apply to your work. So as I said, HTSA plays a role of bringing people together and getting things happening. And I want to acknowledge that we don't do any of this without the people who are in this room. So thank you for your support. So with that, I think that's all my introductory comments. So I'd now like to introduce Professor Stephen McDonald. He's the Director of the Adelaide Epicentre and Director of the Dialysis and Senior Staff Nephrologist at the Royal Adelaide Hospital. I think he might tell us a little bit more about some of those things, but he's also had an affiliation or a leadership role in the ANZ CTR, so the registry that has been instrumental in making a difference in people's lives. So, Stephen, I'm going to welcome you to the stage to talk about a renal dialysis clinical trial case study, expanding SWIFT to regional South Australian health services. I think he's going to give us a bit more than just that as well. So thanks very much for being here. I think what we'll do is just, and I was meant to say this in my opening comments, was just if people have got a burning question at the end of it, we'll actually look to the, to see if we can have a time for questions. And if we don't get time, you have to ask them afterwards. And for the speakers, I'm going to be sitting there and I'm going to give you a 2-minute or a 5-minute. So, you'll need to wrap up when I give it to you. Thanks, Steve.
Thank you, Wendy, and thank you very much for the invitation to come and speak this afternoon. I'd like to start by echoing Wendy's acknowledgement of country and acknowledge that I'm standing on Kaurna land and pay my respects to their elders past and present and emerging. Many of you I've met in the past in various roles, and this year I've been doing something a little different. I've jumped in with the University of Adelaide and part of my time to begin the process of setting up something called a Centre for Clinical Epidemiology, which is a collaboration between the university and Kaurna and SAHMRI, which is based over the other side of the courtyard. Today, though, I was going to be talking not so much about that, but about trials, of course, and how trials and registries have worked together and some of the changes that we have been seeing, making, doing, and hopefully provide some examples for further discussion. Hopefully many of you though know what a clinical quality registry is, and registries are actually a big part of what SAHMRI does. We actually have, believe it or not, have a nationwide reputation. We have one of the two major pillars of clinical quality registries here. There's about 23, 24 registries based here at SAHMRI. Registries, though, are often people find difficult to categorise. It's easy to say, okay, I know what the ICU registry does. I know what the dialysis and transplant registry does. ROSA, I sort of know what ROSA does, but it's a bit different. But they do share a number of very important common characteristics. They're basically all ongoing cohort studies that are very diverse, have multiple aims, multiple funding sources, broad scope, which is one of the things that makes them difficult to define, of course, but they all are very clinically based. That is, they tend to have a very strong link into a clinical group of one type or another. And broadly speaking, there's a bunch of so-called clinical quality registries, and I'm going to talk a little bit more about the ANSATA registry in a moment. There's also a bunch of device or drug registries. So, for example, there's a pelvic mesh registry that's based in Monash that's very important and clearly focused on the use of one particular device. And then there's a bunch of so-called rare disease registries, which are not so much focused on things like quality indicators, but more about creating a platform for understanding of natural history of very rare diseases and also for running trials. Ultimately, though, we hope that registries, and particularly clinical quality registries, fit into this model of a so-called learning health system. Now, many of you, all of you, I suspect, have had involvement in clinical trials out over here. I spend most of my day working down here in the pits. And a lot of the time, this circle doesn't drive around very well. One of the challenges is, of course, how to do that. The Dialysis and Transplant Registry, ANSDATA as it's called, is a clinical quality registry, which has been around, in fact, for over 40 years in its current incarnation, and includes information on all dialysis and kidney transplant recipients in Australia and New Zealand. And there's a bunch of output, very traditional, good quality, clinical quality registry stuff. So information for patients, information to support health service planning, quality and safety stuff. It's all available on the website. And if you would like to go for a tour, please help yourself, Sham, and there are a number of other people in the room that have got really good knowledge of this as well. For a number of years, though, we've also been engaged in trials, not perhaps in a super strong way, but utilising the platform as a basis for adding long-term follow-up for trials, particularly in the area of kidney transplantation, which is a long-term treatment. And traditionally, kidney transplantation trials have been oriented at rejection at 6 months or 12 months or graft failure. But of course, you actually want to know what's going to happen in 5 years and 10 years' time. So we've been able to use the registry to really add a number of long-term outcomes and enhance that trials. And what that led, as well as those sort of particular questions, what that led to was an awareness within the registry circles that there's a lot of benefit from interaction between registries and trials. The paradigm came, of course, a little over 10 years ago with this publication that many of you will have seen out of Scandinavia, and really the first proper registry-based randomised controlled trial. So within a registry, in this case in Sweden, they ran a randomised controlled trial. The question's not important. It's about aspiration of thrombus from coronary arteries. Well, it's very important if you've got having an acute heart attack. But the real message from here was this was, as the headline for the editorial involves, quite a disruptive thing, because what it meant is, okay, well, there had been these two worlds, this registry world and this over here and this trials world over here, that actually had come together and generated a question and an answer. And there are a number of really interesting and really powerful elements to this. And the key to it all is the merger of strengths. So clinical quality registries like ANSTAR are population-based. There is everybody. We don't need to worry about sampling error. We've got everybody, okay? And that creates enormous, of course, external validity. It also creates a fantastic avenue for implementation of results, by the way. Of course, what it lacks is that rigor in terms of we don't have a whole lot of nicely identified trial endpoints and all of that trial infrastructure. And basically out of an observational study, of course, you're struggling to make inferences about causality. So there is this middle ground, though, for questions that can be answered, and they tend to be very clinically relevant questions that are part of everyday clinical practice. There are enormous benefits to where you can embedding trials in a registry, and as outlined here, it helps the registries, it helps trials, and basically it is a good thing. So on the back of a program grant that we got a number of years ago, we explicitly set up a collaboration with the Australian Kidney Trials Network and then with some others. And ultimately, we are running for about to start our 5th registry-based trial, and they've been now funded from a variety of sources. And we've done those across the breadth, if you like, of what we do. And so while you might think, dialysis and transplantation is a narrow field, and I guess in some respects it is, within that there are a number of important groups. And so we've actually now been various designs of registry-based trials running among satellite hemodialysis patients, so people that go 3 times a week along to have their treatment. That's the largest group of people. There's a transplant trial, which I'm going to talk about in a minute, best fluids, and then I'm going to spend most of my time talking about the SWIFT trial, because there's a number of other elements about that are worth talking. But just to touch on best fluid, so this is a really traditional individual level RCT of an intervention. The intervention happened to be use of plasmolite, which is an IV fluid, versus saline after kidney transplantation. People after kidney transplantation make a lot of urine in the first day or two. They often need a lot of intravenous fluids, and many of you might have heard in the concern out of the ICU area that use of saline gives a lot of chloride, and there's some toxicity associated with that. And one of the challenges of kidney transplantation is so-called delayed graft function, or kidneys that don't start. Anyway. So conceptually, this is an individual level randomization trial that was based in the registry, because we actually collected almost all of the baseline data and almost all of the outcome data already. We literally had to change a delayed graft function endpoint from 30 to 7 days. So it was a good one to start with, and it was incredibly successful. And this is a graph that I've never seen anywhere else. It is a recruitment graph that runs complete and ahead of time. Okay. The trial coordinators were actually tempted to modify their endpoints, but common sense did actually prevail, and I said, okay, let's just get it done. But it was a rip-roaring success, and the reason was they leveraged the trials, leveraged the existing infrastructure. It was well suited to clinical practice. It was also clearly and easily implemented, because at the point of kidney transplantation, it's pretty obvious to everybody what's happening. There's a tissue typing process upstream, so there's a signal that can be sent out. So it all worked really well. It was a great exemplar. The other really important points and outcomes about this is that it was a fantastically representative sample. So you can see the results on the right, and it was a positive study, and that helps greatly as well. But I guess a really important message for us, other than early and rapid recruitment, was that the cohort that ended up being recruited was actually about 60% of all transplants done in Australia and New Zealand over that time. It actually had slightly more comorbidities than average, not enough to worry about, and really got away from the problem that we often see in certainly kidney transplant trials, and I suspect elsewhere, where by the time you work your way down all the exclusion criteria, the cohort that's in the trial is not actually as representative, for example, of older people, more comorbid people, and so on. So for us and for the Australian nephrology community, for us in the registry, there were some really encouraging signs there, and the group that were behind this have actually gone on, and I mentioned the 5th trial that we're about to start that's been funded by MRFF earlier on this year, and that's the next step down the line, looking at steroid doses, but with a very similar design. So that's if you're interested in that, that came out in the Lancet about 12 months or so ago. The example that I was going to spend most of the time talking about is the SWIFT trial. And this is a trial that we're doing in conjunction with the NHMRC Clinical Trials Centre in Sydney. It's got some important background. I'm just going to spend a moment walking through why this trial is important. So people who are on long-term dialysis are alive, and that's the point of dialysis, to stop people dying of kidney failure, but their quality of life is a long way from what you would hope. And there are various ways of measuring quality of life, and one of the classic ways is so-called time trade-off measures. How much time in full health would you give up to have how much time on dialysis would you give up to have full health? And generally the answer is, somewhere between 50 and 70% of normal. So that's quite a consistent advice. Now, historically, that's been very consistent. It hasn't improved despite changes in dialysis treatment over 20, 25 years. And that's a whole separate problem. And intriguingly, it's actually lower than what's been reported by people with a number of cancers and other major health conditions. So this is a big problem for the nephrology community. Related to that, and perhaps driving that, is this very high symptom burden, which you can see some of outlined there. What do we do about it? Well, not much. And so one of the key rationales of this trial is to think, okay, well, historically, the symptom burden hasn't had a lot of specific or focus on it as an overall entity. And certainly this relationship between relieving the symptom burden and improving health-related quality of life is one that everybody tries to do, but if in terms of evidence, there's been very little. The other really key trigger for all of this was this study, which you can see now was actually done 15 years or so ago. It's a single centre RCT at Sloan Kettering. Presume that's a good cancer centre. Anyway, so they took about 800 people with metastatic solid tumours. So that's why the survival rate is so poor. And the study was about does collection and measurement of patient-reported outcomes to the treating team, to the in this case the oncology clinic nurse and the oncologist, lead to improved symptom scores and quality of life? And the answer is yes. The other really, really interesting thing is highlighted in this study is it not just did it improve people's quality of life by about 7 points on the scale that I showed you earlier on, but people lived longer, and it's a fairly meaningful survival gain. Both in terms of long-term survivors, the people, if you look at the median survival, it's about another 5.3 months, I think it was. So 2.5 versus 3 years. So that's really interesting. And so what it does show is, okay, well as relieving symptoms and improving quality of life, there's other things that we're picking up just by asking patients about their symptoms and feeding them back to the clinical team. So that led directly on to the hypothesis that underlies the SWIFT study, which is that using, in this case, a renal-specific symptom score, the IPOS renal, and feedback to the treating clinical team will improve health-related quality of life. And that's the headline and the primary outcome. The other thing that this touched on is one of the great challenges in the registry-based world, and that is what we do with patient-reported outcomes, because patient-reported outcomes, patient-reported experience measures are clearly fundamentally important. And there's a lot of effort, and many of you will be involved in that in terms of collecting them. Actually collecting them, analysing them, reporting them at scale is an enormous challenge. It's not a challenge I'm aware of that's been met consistently anywhere in Australia. If you're, for example, the joint replacement registry, it's great to know the survival. It's great to know how many joints are still walking around, but it's even more beneficial to know how many people have pain, how easy are people to walk. So we tend to, in the registry space, that's very difficult because, for example, we've got about 18,000 people on our books, and to collect individual level information from them every year is an enormously challenging proposition, unless you can do it somehow or other electronically. So the second hypothesis, which is not really a trial hypothesis as such, but it's an incredibly important learning experience regardless of the outcome of the trial, because what for us it is a hit out of electronic data collection at scale. So more formally, there's the primary outcome that I mentioned and a bunch of secondary outcomes. And this was the design of the trial, is the design of the trial. And critically, this is a cluster randomized trial. So we're not randomizing individuals, we're randomizing treatment centres. So dialysis is conducted in large hospitals, but it's also conducted in many, there's around about 300 actually, satellite centres around the country and indeed New Zealand. So there's one in Ceduna that's got 3 chairs and so on, one in Clare that's got 2 chairs. And the reason for employing a cluster randomised design is that it was difficult to actually have an intervention that wasn't, if you like, contaminated by the staff and the patients in one chair doing one thing, and then 1.5 or 3 meters actually down the road next door somebody does something different. So that wasn't feasible, but that does generate this whole concept of cluster randomized trial, which I hope you're familiar with. And so the 12-month trial, the control arm is essentially normal care, but with a collection of some EQ 5D. And we've also tacked on something else that came along a long way, which is this concept of dialysis fatigue. So in the formative stages of the trial, there was a series of patient prioritisation workshops by some of our collaborators, and one of the highest priorities for dialysis patients was actually this sense of post-dialysis fatigue, and there was then the development of in a timely fashion, happily, of a validated questionnaire, which we've also put on. So there's a bunch of rationale behind that, and the intervention, as you can see, is quite simply collection and feedback of the IPOS renal scores and the symptom score, and they're sent back to the dialysis nurse and to the nephrologist. We don't tell people what to do in the setup to the trial. People said we don't know what to do, and the outcome of those discussions was, well, we said we would provide some links to evidence-based guidelines, which we do. So very much it's the aim of saying we're going to enhance normal practice, facilitate normal practice. So how have we gone to date? Well, okay, and this is the number of participants. We've just ticked over 2,000, which is an enormous trial by the standards of Australian nephrology. In fact, it's the biggest dialysis trial in the country by some margin. The target from the original power calculations in terms of people, the estimate is 2,400. That's not particularly relevant, of course, in a cluster randomised trial. It's a number of clusters, and we'll get onto that in a minute. The timing of this, if you look closely at the graph, of course, became problematic because of this. And those of you, everybody, I'm sure, can remember 2020 and then 2021 and then into the early months of 2022. And they were really challenging times for the hospital system. They were really, really challenging times for a group of patients that were unwell and immunosuppressed. Having said that, what happened from there is we've got going and recruited consistently more and more centres, beginning with the larger centres and then more recently moving into the smaller centres. So if you look at the number of clusters we have now, we actually have 66. Now there's an enormous gap to the 143, which is if you like, the target number. It's actually, we don't need, because of something called the intra-cluster coefficient code. We actually are going to end up needing a little less than that, about 120, but it's not as bad as it looks, and you might think, how the hell are we going to get there in the next few months? And the reason is where we are now, which is recruiting regional units. The math sort of looks like this, and so that the size of the units we've got at the moment predominantly is people with 20, 25, 30 patients. And I mentioned that, for example, the Ceduna unit has about 10 patients at the moment. The unit at Clare has 4 or 5, and so on. So one of the things we did, and one of the things the registry facilitates, is in this trial, we very explicitly early on said we are going to go out into the regions and we are going to recruit far and wide. And that's led to a really, well, at a very basic level, a number of geographic journeys, but a number of really interesting exercises. South Australia, I'll talk about more in a moment, but Victoria, we are well down the path. In Queensland, we're well down the path. And just to give you some examples of the sites where the discussions are at the moment, in the last month or two, we've been opening up, and very much in regional Victoria. And there's, as you can see from the figure there, that generates a large number of clusters. There's 11 clusters we hope will come online in South Australia later this year. There's another dozen or so in Victoria. There's another 15 or so in Queensland and then Western Australia. So it's all, we plan going to come together in the next 6 months or so. Now, having said that, there's been a number of other really powerful stories about that. And the picture up there is the crew in Bairnsdale and a chap called Justin Hamilton. And this was their site initiation visit, and that's normally very routine. This was the first clinical trial that the renal unit had been involved in. This was actually also the first clinical trial that Bairnsdale Health Service had been involved in. So this is part of the sort of the novelty of it all. There are challenges to that as well. And of course, one of the challenges is getting support out to them. But a trial that involves recruitment via signing your name on an iPad or a tablet, and it doesn't involve any biological samples, doesn't involve trial visits back and forth, can all be done as part of routine clinical visits, is a really great way to introduce the concept of trials to people that have never participated before. So as I mentioned, there are a number of elements about the trial that were very specifically designed to be pragmatic and to facilitate regional uptake. And you can see there where we've been. And also what I haven't put up there is where we're going. And I mentioned South Australia and Victoria. Thursday Island, Bamaga, Weipa, Orocoon are also very much on the coming later on this year, hopefully, if not very early next year. So that there's this enormous spread. There are a number of other elements to it that we did that make it very, if you like, pragmatic. One is on the getting through, just being able to sign your consent with your finger, as Rachel's demonstrated at the bottom. Second is the use of a tablet, and that's, gosh, been a real learning experience. This trial we designed in 2017, and when you think about the number of people who have iPads and phones now, it's very different to 2017, and we do things differently. But it's been really interesting learning about that. It's big, it's really representative. I haven't shown you the data about that, but it is entirely representative of the Australian dialysis population. So South Australia was actually where this trial began. We ran the pilot out of Gawler with some support from Kidney Health Australia, and some of the major metropolitan dialysis units have done it, and we were up to, at the moment, in conjunction with Teletrials, is actually just on the verge of getting going across the regional sites in South Australia. So we've got 13 regional dialysis units in South Australia. Gawler have already done the main trial, and the remainder, as you can see listed there, will be hopefully getting up and going very soon. In conjunction with Teletrials, and that for us is a different model. It's a collaboration with some other partners, and I'm sure they'll speak about that, how that's going in a moment. And then from here, WA and Queensland and regional Victoria I've mentioned. So that's for us the SWIFT trial. From a registry perspective, it's really helped engage and drive things out in regions. But from a research and a trials perspective, I guess that's been the more powerful deliverable. It's actually gotten people engaged and involved in the research process that haven't ever been engaged before. So if you want to find out more, please, let me know or jump online. And thank you for your attention, and very happy to answer some questions either now or later.
So there's two questions. Anyone who's involved in the SWIFT trial out there, or potential?
I saw Laverne Greenham and they all, yeah.
Amazing. Any questions? Yeah.
I just want to ask, I really like the idea of...
Hold on, just wait for the mic, because we've got lots of people online. It just helps with the people hearing. Thanks, Emma. Thanks. Ciao.
Thanks for the great talk, Professor McDonald. I just want to ask, with the patient-reported outcomes, and I really liked the idea of clinicians actually using the data which was encouraged for your trial. Do you anticipate that will inform future work of informing, because getting clinicians to use it is one thing. There's a lot of investment in collection, but that use side of things.
So there's a bunch of other stuff that runs alongside the trial. There's a qualitative study about that explores some of those issues about what are people doing with the information. I guess there's a fundamental, the next steps, I guess, fundamentally depend on what the trial outcome is, but it's almost certain that there's going to be some form of ongoing patient-reported experience or outcome measure. collected. But that qualitative piece about how people use the information will answer some of those questions. The other challenging thing, though, is how does that information get incorporated into electronic medical records? Because most EMRs and most hospitals are not routinely having patient-reported outcomes incorporated into their EMR. So there is a piece around that, and so I don't have there's not an answer for that at a nationwide level, I'm afraid, but it is an important thing in terms of the other thing I should have said, in terms of the patients, those that are in the intervention arms also get the option to have their scores sent back to themselves as well, both their current ones and their trend over time.
Hi, I'm Melanie Poxton from the AT Queensland team. So we formalised SWIFT in Townsville with the dialysis unit there. Has anybody else actually used the teletrial model to formalise into the cluster like we have in Townsville? Is the first question.
Pascal can speak to South Australia, but yes, that's not other than South Australia and Queensland. No, not in.
And South Australia had the supervision plan and all of the documents.
It's underway.
And my other thing is to say we have done that. So if you want a template for a supervision plan, we are happy to help.
Yeah, that's wonderful to know. There's a long discussion out there about teletrials and the advantages and disadvantages. Yeah.
Right. Put your hands together for Professor McDonald, and we very much appreciate your generous time, spending time with us today. Look, I think one thing it says to me is how much we can leverage the opportunities to actually build into regional Australia with these projects by thinking a bit differently and really using the opportunities that they present. So thank you for your talk, and hopefully people can take something home from it. And the idea of embedding clinical trials in registries is just such an asset for the country if we can actually make that happen more widely. And I think there's a number of people who are thinking about that, and then it's a matter of them coming together and figuring out how to do that. So there's lots of opportunity. So thank you very much. Okay, we're now going to move on to the next 15 minutes. It's going to be interesting, and I'm not quite sure how this is going to work. So I'm trusting here that we're going to talk about, we're going to have 3 of the nurse consultants from the ATP program talking about it. Oh, good, she's doing it. Come on up.
Hi, everybody. So good to see you all.
And you are?
Yeah. What did you want me to do? Okay. My name's Charlotte Goas, and I've joined the ATP team just recently as a nurse, as a clinical trial coordinator. And these guys I want to introduce are the heart of our organisation. So without these nurses, we wouldn't be running ATP. So I'd like to give them all a big warm welcome. Is everybody there? Yes, we got it working. Woohoo!
Hopefully everyone can see my screen sharing. I have no idea how to tell if you can or can't.
Yep, we can, no problem. So onward and upward.
Fabulous. Thank you, Charlotte. So welcome everyone. My name's Emily, and with me today is Jane and Elise, and we're here to present on our experiences today in paving the way to increase clinical trial access in rural South Australia. So being a rural clinician is a unique and challenging yet extremely rewarding lifestyle. Many say it's being the jack of all trades, but the master of none. Although I would challenge that having the adaptability to excel in providing both clinical care in such a variation of presentations while noticeably under-resourced and staffed is a true skill in itself. When we work rurally, our communities are a part of us and they're at the forefront of our priorities. Experience in being a rural clinician is really what has set us up to taking on this role, not necessarily the clinical trial experience. If we were not rural clinicians, we would not have had the breadth of understanding of how the rural health system works, but also the ability to juggle between the administration and clinical components of the role, really meaning that we would not have come nearly as far as we have today without it. We are actually the first clinical research coordinators within rural South Australia to date. Our positions first commenced in March 2023 with 2 nurses in Mount Gambier and in the Riverland. It followed shortly after with another nurse in Whyalla, where that position is actually currently vacant. And then this year by recruiting our last lovely nurse in Port Pirie. Initially, when we started, understandably, no one knew we existed. This was a brand new role, and to many of our rural hospitals and those who are within us in our hospitals, they weren't really on the radar for them at that time. Further to this challenge, we were really grasping with the concept of how can we expect others to understand our role, and we're still grasping at the ins and outs of it ourselves. So aside from your good clinical practice training, there's really no formal education for people who do work in clinical trials. And historically, it's been a learn on the role type of role and position. But when you are isolated and you're the sole clinical trial coordinator or researcher in your location, that's really not possible. A part of our early and ongoing role has been involved in assessing and identifying how we can build the capacity and capability to manage clinical trials in our local health networks. So this has been done using the maturity scale, which was created by Anne Woollett in rural Victoria. This determines the growth and development within clinical trials within each region. So starting from level 0, which is your formative, up to a level 4, which is leading. It looks at areas like what infrastructure, so what departmental capabilities and requirements we have to run clinical trials, the type of leadership and executive support and culture, and including awareness of clinical trials and research, what technology we have, the skilled people who are there on site and then also accessible virtually, and also what sort of professional networks and collaborations there are. What we've learned from this is that to promote growth, we need to focus on our weakest links because we're only as strong as our lowest area on the maturity scale.
Hello. At the commencement of our roles, we decided to undertake a bit of a scoping exercise within our local health networks and community, just to gather some information around the awareness of clinical trials, and mostly, it was thought that clinical trials happened in the major tertiary facilities. And indeed, this was very true historically, with only maybe 1 or 2 clinical trials taking place in some regional LHNs. So based on that, we needed to establish effective communication channels that delivered information and education around clinical trials in regional settings in a purposeful way. So how did we do this? Well, we began engaging with government and non-government organisations, either through doing group presentations, individual presentations, or by one-on-one conversations with key stakeholders in our region. On average, we started out with around 1 to 2 engagements per week, and even up to today, we've continued those engagements with our key stakeholders. As a result, we've created a continual network of ongoing connections, which has actually led to patient referrals for some of our current clinical trials. Challenges in regional settings. Look, we could list so many, but really we just wanted to share with you our top 3 challenges, and probably were critical challenges for us to navigate. And the first one is 1 RGO for all regional LHNs, meaning that processes have to be approached collaboratively between our LHN and our regional RGO, which often requires greater consideration and detail for varying approval times of clinical trials in regional settings. Number 2 is sharing of facilities. In regional settings, we're often sharing rooms with so many different professionals, and with no actual dedicated clinical room to see clinical trial patients. And, the high demand for space is ongoing. us coming into this environment increases that sort of competition for space. But once we established ourselves within the local health network, we actually we had to begin to build, foster and develop new relationships with various departments just in order to secure a clinical space, which has actually been critical for clinical trials due to the complex assessments and the time required with clinical trial participants. And of course, as more trials, come through, the busier we become. And, this challenge for space will be ongoing. Undoubtedly, probably the biggest challenge we faced, and this may be news to some people, but we actually didn't have a dedicated office space within our local health network when we started. It actually took us around 6 months to secure an appropriate office space within our local health network. This was our greatest challenge because we needed to be on site for various legal reasons, running clinical trials, but we also needed to build relationships. And when you're not seen, you're kind of an invisible person. And once we were within our, office space within our local health network in that sort of prominent position, we then had the opportunity to start building those critical relationships with our key stakeholders in our local health networks. I want to talk about investment, and when we think of investment, we're thinking of financial investment. However, we want to share with you an investment from our local health network stakeholders and the community investing their time in us. In the beginning, we really struggled to get time with our stakeholders. But we're actually at a point now where we're sitting down with our regional local health network executive teams, and we're creating flowcharts, we're developing frameworks and helping to streamline the processes for clinical trial implementation. We're also having input from local specialist teams, engaging in regular meetings to discuss potential clinical trials. We're preparing local clinical trial investigators. So looking back where we were in the beginning to this current day, we are seeing some exponential growth in the clinical trials with improved collaboration between health professionals to achieve our targeted outcomes.
Having come into the role later in the ATP program than Emily and Jane, I would like to take this opportunity to acknowledge all of the work that has been done already by everyone that's been involved and that has brought access to clinical trials to their communities. The areas that we have been able to provide clinical trials in so far, multiple mental health trials, some multiple oncology trials, obesity, renal, preconception, endocrinology, metabolic disorders, Alzheimer's, peer support, mental health. I have been able to massively benefit from Jane and Emily's experience. Their willingness to share their knowledge and experiences have given me a fast track in this role. Collaboration in this role means that we can learn and benefit from each other's experiences and help streamline the processes within our own LHNs. Another benefit of collaboration that we're hoping to further develop is working on the same trials and being able to translate those across our different regions. And that collaboration will eventually help us streamline not only the ethics processes, but also the implementation on site and can make future trials more streamlined. We have learnt that while all of the regional LHNs have a lot of similarities that just come inherently with being a regional service, they each have their own ways of doing things that are due to the differences in geography and the local communities. Navigating those differences are why we are spread out and work on country within each of our own regions. Part of our role is to increase the capacity and capabilities in our regions. And as Jane said earlier, investment equals growth, not just in infrastructure, but in human resources as well. We've learnt that clinical trials and research require more than one person in each region. What we've learnt is that we actually need a full research team of support to continue making progress. We need a team to cover all of the elements needed to develop regional and patient-specific research goals local in our area. Each regional LHN has their own needs, setup, processes, governance, policy and process development, and clinical services. So the investment needs to be local in order to meet the needs of that specific community. We need to invest locally to increase capacity to facilitate the trials, governance, and meet accreditation requirements. We have learnt that to do this, that we need continuing executive support and interest to keep driving us forward. And we have also learnt that while each LHN has slightly differing needs, we all come back to the first priority of healthcare and continue to be focused on the same thing, which is improving the care of our patients. We would like to acknowledge the funding and ongoing support that has made our roles possible, the ATP and our SAHMRI head office in Adelaide, the Riverland Academy of Clinical Excellence, Flinders Uni, and USA Department of Rural Health.
Fantastic. Put your hands together. What a great presentation, and thank you to all of you for your contributions. That was amazing. And I think it tells the story of the Teletrials program and how it has evolved, and the importance and the strengths of embedding research in health services and the things that can come out of it, that having that executive support for research. We know that research-rich health services have so many benefits for staff, for patients, for everybody who's involved. So I think this is an example of exactly that. Because we don't have heaps of time, I'm not going to go for questions, but I'm sure there are people, questions that you may like to put to these guys at some stage. So we'll set up that mechanism. And certainly there are people here today who are also involved in the Teletrials program. So encourage you to continue to do that. So I think we won't go for questions unless anyone's got a burning one. No? So let's put your hands together for these three guys. Thank you so much, and please, hopefully you're involved with the rest of the day, so you're online for the rest of the day. So thank you very much. Okay, so we're going to move on to our next speaker now, and thanks for the technology people that made that all work. It was great. So our next speaker today is Renee Deschaines. Renee is the Training and Development Officer for the Australian Teletrial Program in South Australia. She's going to speak to us today on training opportunities. She's going to speak about AC Tech and the 2 years of supporting clinical trial education in South Australia and what that means, and also launching the South Australian Clinical Trials Community of Practice for clinical trial coordinators. So I'll welcome you to the stage and look forward to hearing from you.
Hello, everyone. Right. Thank you all for having me. As Wendy said, my name is Renee Deschaines, and I am the Training and Development Officer at ATPSA. So the first little bit of my presentation is going to be giving a bit of an update on AC Tech, which is the Australian Clinical Trials Education Program that we shared with you all last year at this same event. So if you haven't heard of AC Tech, I would encourage you to check it out, make an account. It is free to everyone. We have, in conjunction with the AC Tech team, been able to fund this access to this platform for everybody. It doesn't matter what your role is, it doesn't matter how much experience you've had in the space, and it doesn't matter what organization you're from. If you would like to access AC Tech, it is there for you. And so here's a little, wow, that's not what it looked like for me. Well, we've got a little bit of a squinchy slide, but the numbers still are true. So this is just a bit of an overview of the registrations by quarter. And so though it's a little bit more compressed than I was hoping, it really does show that we've had a really steady increase in users joining the platform since we launched in September of 2022. And particularly, I'd like to point out that in Q3 of 2024, that doesn't even actually include September. And already we can see that we've surpassed our previous record. I keep hitting this one. So specifically, I'd also like to draw attention to the little yellow or orange sliver, and that represents our clinicians and professionals who are from MM3 to MM7 communities, which represents our rural, regional, and remote professionals. AC Tech has been a huge part of our effort as ATPSA to bring more equity around access to clinical trials education, and we're always enthralled to see that the clinicians working regionally are taking advantage. And so another squinchy slide here, I do apologize, but this is just another representation of now the course completions, because not only do we want people to be joining the platform, but we'd also like to make sure that they actually are engaging with the content and finding it helpful. And this is as well another one where you can see that really promising upward trend that has demonstrated to us that there was a real need, and that AC Tech has allowed us to be part of addressing it and hopefully finding a solution. So now that was just a little quick update on AC Tech, but what I am most excited to share with you all is something that myself and a group of coordinators across several LHNs have been working behind the scenes to bring to life. And so I introduce you to Compass SA. Now, I'll skip this because you all know me. So I'm going to be talking about what Compass SA is, what it means, who it's for, a little bit more about what exactly we mean by a community of practice, and then, of course, the most exciting part, which is the group that we did as part of a focus group, as well as what's on offer, and then we'll get to meet a few of the community members. So let's jump right in. So what is Compass SA? It is a community of practice for clinical trial coordinators at SA Health. And so our vision is to facilitate a collaborative clinical trials environment in South Australia, where coordinators working in both metropolitan, rural, regional, and remote communities have equitable and localized access to networking, professional support, resources, and education opportunities. As ATPSA, we've been working very closely with our fabulous nurses, which you have just had the opportunity to meet. And through our work with them, it further highlighted this inequity that we always knew was present. And we've, taken it upon ourselves to be part of finding a solution in terms of ensuring that all coordinators have access to equitable education regardless of where they are located. And now our coordinators working regionally and remotely feel that disparity the most, but while engaging with our networks, it was quite clear that even coordinators located in the city felt this feeling as well. So Compass SA is a part of us working towards a solution. So who is it for? We did a lot of work to determine which group of clinical trial professionals were feeling that inequity the most. And it was quite clear that clinical research coordinators and trial coordinators were the ones. And so I have listed out all of the specific professions that fit into what we would describe as the terms of membership. But at the end of the day, what's the most important part is that if you have on the ground trial coordinating responsibilities, and that you are an SA Health employee, this is a space for you. Even if you don't have the formal coordinator title, we all know that in clinical trials, things are not always cut and dry. So that doesn't mean that you are not welcome to join. So please just keep that in mind if you're sitting in the crowd going, oh, I wish it was me. It very well might be. And so at this stage, it is SA Health employees specifically, because we are resourced by SA Health. But as we grow, we want to explore expanding to other communities as well. We know that the public health sector is not the only group that feels this inequity of access. And this is something that we're really keen to explore in the future as we progress. And so I'd love to quickly define what a community of practice is in order to best understand what it is that we're trying to accomplish here together. And so a community of practice is a group of individuals who are brought together by a shared domain, a community, and practice. And in this case, our domain is on-the-ground coordination of clinical trials and teletrials in South Australia. The community, as much as we'd like to always be together in person, it is through MS Teams online. Because that is a huge piece of ensuring that equitable access, is that it doesn't matter where you're located, as long as you have access to your computer, then you will be able to join us and be connected with other members of the community. And the practice, of course, is all around professional development. So this means lessons learned, resources and tools, educational opportunities, mentorship, and networking with other coordinators who share your interests and goals. So I'd like to pause here and talk about the compass part specifically. And this is something that myself and the focus group came up with together. We wanted to pick a name that was memorable, and we really tried to turn compass into an acronym, but there's only so many letters of the alphabet, and we just had to concede in the end and choose it as a title. But the reason we've selected it is because we feel that it really captures the ethos of our community of practice. A compass is a tool that provides direction and guidance to those seeking navigation. And that this community of practice serves the same purpose. It isn't necessarily a place where you'll come and get all the answers, but if you are searching for what you need to know, you are welcome here, as many of the other coordinators present are on the same journey. And so now, this is the best part of the focus group. When we were working behind the scenes to bring this to life, I knew that the most important part was that this group had to be co-created with the community that it aims to serve. And that couldn't have been done without but 16 really dedicated coordinators who put their hands up to join me on this journey of implementation and determining what shape that this group should take. We met fortnightly for 3 months. They were very generous with their time. And we had representation from Colin, Solin, Nolan, Witchin, and RMC. So with their help, they were able to share their expertise and their perspective, and we were able to ensure that what we put together was something that met the needs of coordinators across South Australia in the public health space. They've also been fabulous to start cultivating a collaborative, safe, judgment-free space and build interest at a local level, and also work towards sustainability of the initiative. And so now, what is on offer? This is what we have to date. So the online forum, of course, is Teams, where you're able to chat directly with others, which is, sounds so simple, but really, when you are in a role, especially one that you're still getting your feet under yourself, having somebody to tap on the shoulder and ask a question is worth its weight in gold. And even though this is an online forum, it really allows you to know that you have a group of other people who understand what you're going through and might be able to point you in the right direction. And so the resource library as well is going to serve as a growing repository of resources. We like to think of it as all of our favorite resources in one place. It is searchable, it is organized as well. I need to stop doing that. And it includes webinars, online courses, modules, whatever it is that you might be looking for. So if there's a specific topic you have in mind, you're able to visit the resource library and hopefully find a resource that will help support your learning in that area. And lastly, something we're working on as well behind the scenes is the knowledge exchange. Members are able to opt in to participating and, can each self-declare their areas of knowledge. This can be areas where they have significant experience or expertise. And then everybody within the group is able to review this directory of contacts, if you will, and identify people who might be willing to collaborate together, might share an area of interest to them, or might be able to provide, some advice or answer a question on a particular topic. And there's more to come, of course. With one of the biggest parts is that with the community, as we progress, we'll be able to put our heads together and figure out what it is that is a most pressing need felt across the group, and then come up with initiatives that will hopefully alleviate those pressures. And now, enough of me talking and hitting this microphone. I'd like to invite Rajesh on this stage. I'll give him a warm welcome. He is a clinical trial nurse from Colin and has been working in clinical trials for 6 years. And I will give him the floor to share a bit of a testimonial.
My name is Rajesh, and I'm working with the stroke clinical trials from the last 6 years. When I joined the stroke clinical trials I was working in the ward nurse, and then I joined the platform as a coordinator. It took me a while to understand the terms like, oh, what is PICFs, GCP trainings, although I've done all the trainings, but getting into the role of a clinical trial coordinator was not very easy. So I think like this kind of a platform is a really useful thing, specifically when you are joining as a new. Also, when you are like, for example, I'm say 6 years old now in this role, still I feel and face situations which are a little bit challenging at times. For example, just a couple of months ago, I just enrolled a patient who, instead of using the cab charge, which was given by a sponsor, just took his credit card and paid from his credit card. And he said, all right, there's a receipt and this is $75 I paid from my pocket. What to do in this case? All right, it's little things, but actually it's a long-term study, 3 years. I don't want to lose a participant because he paid from his own pocket and there's no way I can pay from any of the funds. So, but there is some options which the amount can be reimbursed from, like forms and all that stuff. So these kind of things like exchange of information is really important and can be really useful. And this forum, I think like it is going to be really useful in the future. Yep. Thank you.
Thank you. And there are actually quite a few members of the focus group in the crowd today online. I won't single them out. I promised I wouldn't, but thank you all for being here and for supporting. And thank you, Rajesh, for sharing, a part of your experience. I think one thing that we've really felt across the board as a common denominator in experience is that a lot of coordinators have had to learn by doing, and sometimes learn by doing things incorrectly and then learning from that as well. So this is hopefully putting everybody in a position to have a little bit of an easier time than the people who came before them. And now another testimonial that I'd love to share is from Deb Hobbs. She is lovely. She is online. Sorry, I said I wouldn't do it, but hi, Deb. And she works at Nolan and has been in clinical trials for 1.5 years. So she shared with us, I entered clinical trials as a novice in a niche nursing role in my clinical directorate. A community of practice would have provided me with great opportunities to problem solve, limiting frustration and time wasted developing resources and learning processes. I would have loved to access a professional community of practice so that I could have quickly identified supports and potentially a mentor who may have assisted me in developing my professional skills and confidence quickly. The opportunity to reach out and connect on a personal level with others within my organization would have made an immense difference to me. I feel sure that Compass SA will be a fantastic networking opportunity and an important source of inspiration and support. And now, last but definitely not least, a testimonial as well from our nurse, Emily Matthews, who you all met before. She works in the Riverland, has been in clinical trials for 1.5 years, and this is what she wanted us to share. The Compass SA community of practice is filling a gap of disconnect across clinical trial coordinators in South Australia. It's creating equity for those of us who have to work in isolation and have been learning the ropes with limited educational resources and even fewer opportunities for guidance and support. Being involved in the development of Compass SA through the focus group has been both insightful and empowering to be able to represent rural-based clinical research coordinators to ensure that our needs and goals are also recognized and intertwined within the philosophy of the group. And now, last slide. An official thank you to the focus group, of course, our Pathfinders. And please, if you would like to join, scan the QR code here. And if you are not within SA Health, please feel free to register your interest as well. This really is something that we'd like to explore. And so if we're able to demonstrate that need and interest, then hopefully we'll be able to move in that direction. So thank you all for your time.
Thank you so much. Have we got a question for Renee? I think the best thing I just heard was, one, that Compass has been launched. So congratulations to everyone who's been involved. Very good. But also that your last comment that people who aren't in SA Health, who are interested, to put your name up there so we can see that there's a volume of people that are interested, because I think that is our real opportunity to actually grow outside of SA Health and be thinking about the skill sets that reside in SAHMRI, reside in other academic institutions and across the private hospital system as well. And I think you'll find that that really will be where we can go in the future. But congratulations on the work and getting to this place. It's fantastic. So congratulations. It's an exciting opportunity. I just wanted to reflect on the SA Health have an implementation science group, which sort of started in a very similar way, where they actually have a big network of implementation science professionals who are working across SA Health, who have built a great community of practice within SA Health. We've now been able to have the lead of the implementation science group sit on a statewide leadership group that is about implementation science, linking the expertise from the academic institutions together with the health service. So that's actually where we could potentially think about moving with this. But congratulations on that. And also congratulations on those numbers around AC Tech, because I think that is a great opportunity for people. If you have people who are members of AC Tech, little show of hands. Okay, most people, but not everyone. So I really encourage you to join up and let's see that trending data even better. And sorry about the numbers getting a bit wobbly. So we're now moving on to our next speaker, and that was really good to hear that whole celebration of the ATP program in South Australia. So we're now moving on to SAHMRI clinical trials, and we have Emma, who's already been asked a question, so she's been involved a little bit, but Emma is the Senior Manager of SAHMRI Clinical Trials Platform. She's going to provide an update on the clinical trials platform and what it offers. Also look at registry-based clinical trials, and that was something that Stephen mentioned as well. What are they and how could they how do they fit into the trial landscape? So welcome, Emma, and come on up.
Okay, good afternoon, everyone, and thanks, Wendy, for the introduction. I recently joined the Clinical Trials Platform team, and I think most of you were here last year, so you would have had a bit of an update last year, so I'll keep it short. And then I'll move on just to talk a bit more about registry-based clinical trials. I have a background as a physiotherapist and then moved into the registry space and medical device trials related to orthopedics. And so I thought it was timely to talk about registry-based trials, and it fits in nicely with Stephen McDonald's introduction this morning. Okay, so since recently joining the team here at SAHMRI, there is a consistent question that I'm being asked, and that is, what does the Clinical Trials Platform do? Well, our purpose is to provide support and services for clinical trials from phase 1B to phase 4. We support local, national and international clinical trials, and we serve a diverse range of therapeutic areas. So to name a few: cardiology trials, oncology, gastroenterology, metabolic disorders and medical devices, to name a few. We are made up of a team of project managers, project coordinators, clinical trial research associates and clinical trial nursing staff. And in principle, we're an academic research organisation, so you'll more often than not find us involved in supporting investigator-led trials. But more recently, we've expanded in what we do, and we now offer services and support to all parts of clinical trials, and we do that for industry, other CROs, biotech companies or pharmacy as well. And here at SAHMRI, we also act as a site for clinical trials and in particular community-based clinical trials. And in this fashion, we partner with GPs, allied health and specialists. And we mightn't have many clinicians in the room today, but just by chance, if you're a clinician that have an interest in a trial, we'd love to have you on board as a principal investigator or sub-investigator, and we can certainly provide training opportunities for clinicians to be involved as we want to really grow the trial space with all clinicians, not just that select few that are interested in trials, which I think is a real problem that we all need to address as a group. On the screen, I've outlined the ways that SAHMRI's clinical trials platform can assist with clinical trials. So project proposal and design, project management and study coordination. We have particular expertise in ethics, governance and regulatory requirements, and data management, so we can support data entry, database design, right through to all that required reporting that's associated with trials. And also we have auditing and monitoring through our clinical research associates. And we also run very effective digital marketing campaigns through a partnership we have here at SAHMRI. And I put up a few of the digital marketing campaigns up on screen just to show you some of the examples of what we're running. And as you can see, the digital marketing is very specific to attract the right participants to trials. So in that case, we've got a type 2 diabetes example, irritable bowel syndrome, and a study for planning pregnancy. Another thing I'd also like to mention is the partnerships within SAHMRI that the clinical trials platform has. So we work really closely with the biostatistics unit here, and so they provide analysis for trials. And we also work closely with a lot of lab-based services, so cryogenics, flow cytometry and mass spec, just to name a few of the services that are available at SAHMRI and the technology that is increasingly being put into contemporary clinical trial practice. So there's a lot more going on, I guess, on the bench side that some of you aren't aware of that's at SAHMRI. So in summarising SAHMRI's clinical trials platform, we're essentially here to make clinical trials easier for researchers as well as industry. We can be quite cost effective compared to commercial groups. We are efficient and we still have a focus on quality. And we also are flexible in that we can support all parts of a clinical trial or just piecemeal, depending on what services people are available. And we are flexible, but I can't say we're quite as good as Simone Biles. Now that I've given that quick overview, I wanted to talk to you a bit more about registry-based clinical trials, and I'll keep it pretty simple for those of you who are well-versed in trials, but lots of people actually have no idea about registry-based trials, although Stephen's given a bit more of an overview, but I'll expand on that a little bit further. So firstly, what are registries? The formal definition can be seen on the slide, but put simply, registries typically collect and analyse observational research data, and they're aimed to achieve better patient outcomes and care across the entire healthcare system. And so why are registries important? They're important for quality control. So an example actually from a registry based here at SAHMRI, the Trans Aortic Valve Implant Registry, so that's a cardiac valve implant registry. They actually use registry data for clinician accreditation. And registries have also been used to change clinician practice. So an example from the National Joint Replacement Registry, there's no longer a huge use of kneecaps in total knee replacement surgery. Oh, kneecap devices, not kneecaps. So not that device is no longer used. And that's been informed from individual data that's been provided to surgeons, and that resulted in a huge change of practice within orthopaedics. Registries are also important for policy reform. So a great example, again, from a registry here at SAHMRI is with Maria Inazio's group, the Registry of Senior Australians. And they provided important information to inform the Royal Commission into aged care quality and safety. And that was for the ongoing evaluation, monitoring and improvement of the aged care sector. Registries are also really important in effective post-market surveillance. Another example from the National Joint Replacement Registry, which is that picture up the top there, is metal-on-metal hip replacements. So back in 2010, it's a while ago now, isn't it? There was a worldwide recall of that particular device, and that was due to what was noticed in the registry was a huge failure rate of that hip replacement and subsequent issues associated with the metal-on-metal rubbing, creating metal iron and toxicity related to essentially poisoning in the blood system. And that was thanks to registries, that this could have kept going a lot longer and had a huge effect globally on a number of patients. And thanks to registries, that was able to stop and worldwide practice was changed. And now here's the big one, registry-based clinical trials, which I guess I'm trying to drive now for all of us to be more involved in this space. Traditional clinical trials, well, they're not suitable for everything, are they? You can't really imagine running a well-designed randomized controlled trial on parachutes to reduce injury risk. And this is where registry-based trials can fit in as their observational data set. So what is a registry-based clinical trial? Well, I spent time looking at the literature and there just isn't a standard definition within the literature. But what I can tell you is registry-based trials is where some of the patient, the treatment, or outcome data is captured in a clinical registry rather than a standalone trial database. Existing registries can also be used to identify potential participants and at a low-cost option to answer important clinical questions. The questions usually have a focus on capturing a limited amount of data that is critical to evaluate the trial outcome. This data is generally captured as part of routine practice or just a part of standard care, which I think is what sets registry trials apart. I wanted to show you a practical example. It's a busy slide, but that was taken directly from the graphic of JAMA. So this was an orthopaedic multi-centre cluster randomised registry nested crossover trial. In Australia, it's actually routine post-joint replacement to prevent deep vein thrombosis, to have medication after your surgery. And so the two medication options that are available in Australia is just standard aspirin or low molecular weight heparin, which probably most of us just know as Clexane. And in Australia, it's routine for the surgeon just to pick or choose, depending on their opinion or hospital practice, which one to use. And so the Australian Orthopaedic Association National Joint Replacement Registry used their infrastructure to design a trial, so using their data collection systems, to be able to compare the two standard and routine medications within a huge population that was gathered. And the trial, as you can see, ended up actually showing a difference between those treatments that today are still used prophylactically for treatment post-joint replacement. And it really highlights the need for a cost-effectiveness analysis to then determine, hey, should we actually be changing practice? And so I think this really highlights the power of registries and how they can work with clinical trials, as this can really change practice not only in Australia, but on that global scale. And so then what are registry-based clinical trials best for? So I think as per my example, they're really good for asking questions about the use of existing treatment options that are already out there. So rather than being used in those early phase studies or in unproven agents, and they're typically used in single arm or randomized phase 2 or 3 studies, although don't hold me to that because I did find other ones when I was researching this topic for today. And so what are the advantages and disadvantages? As you can see, the advantages are listed. They can be really cost effective and efficient because you're already using established infrastructure. And registries also allow for really large sample sizes, which you could see from my example on the earlier slide, as well as Peter McDonald's example as well from the ANZ registries. And they have great external validity as they're used in real world settings. So they don't have that tight control of a standard trial, but it allows for that really good real world applicability, which is really what we're all after in being involved in clinical trials in the first place. And a real plus is that it's embedded alongside routine care. So it's just part of standard practice. The disadvantages, however, and they're nothing to not consider, that's for sure, is data quality. It mightn't be as rigorous. So in registries, there is missing data sometimes. And so that's something you need to factor in with trial design. And also there's often a need to link to other data sets. And I'm sure plenty of you have been involved in data linkage exercises. A lot of ethical issues and timely that take a really long time and also can be quite costly. And then there's the methods challenges as well as operational and infrastructure challenges. Even though you're using existing infrastructure, that also is a challenge in that kind of stuck with what's already there to use. So you really have to assess and work out if it's feasible for your trial. And also the ethics and governance issues. So the registries use a different framework to the clinical trials framework. Whilst there's lots of similarities, you still need to be pretty careful in your setup. And so some key takeaways. Registry-based trials have a population that is ready to go and it's waiting there for you. And it's really something I'd like you all to consider. And registry-based trials can also complement our standard randomised controlled trials because they can provide additional evidence of the effectiveness and safety of interventions in the real-world settings. And importantly, I think there's real opportunity here for all of us as clinical trialists to work in registry spaces and collaborate together. And so I think that's a really exciting space, and I'm glad Peter talked about it today as well, as it's something that's untouched for a lot of us and something that we should think more about. So that wraps up my 2 short talks. If you'd like to have a chat to me about SAHMRI's clinical trials platform or anything else, please do. The coffee's there to catch your attention. I love a cup of coffee, so please feel free to reach out and have coffee with me. Thank you.
Thanks, Emma. Great presentation, and really interesting to have a think about those embedded clinical trials in registries and have a chat with people. There are a lot of people around in SAHMRI that are very savvy around registries, and if that's something that you think might be a good way forward for you, please reach out to Emma or others that we can put you in touch with. So now we'd like to move.
Excuse me, there is a question online.
Oh, okay. Yep.
Do you charge for the platform resources? Thank you.
Platform resources. Yes. Yeah. Yeah. So the answer is there is a fee for service. However, you ensure that it's within reason and something that people can. Yeah, we like to enable people to do things. So that's part of the game. But certainly there is a cost recovery methodology. Okay, so I think we'll move on. Our next speaker is Natalie Kutry, who is our project manager for Health Translation SA, and she's going to talk about the HSANDA program, which is the Health Studies Australia National Data Asset Program. And some of you, again, will have heard about it last year, but we're looking forward to the update from Natalie. Away you go.
Thanks, Wendy. Okay, so today I'll be talking about HSANDA, which, as Wendy stated, stands for Health Studies Australian National Data Asset. So HSANDA is a national program that facilitates access, sharing and reuse of research data. It aims to support more efficient and effective research to help improve health outcomes. This was a strategic partnership with the health research community to build digital infrastructure, and part of this was developing the HDA online portal, which is the Health Data Australia portal. To date, there are 9 HSANDA nodes. These are national groups that represent over 70 health research organisations. This collaborative approach was co-designed by the Australian Research Data Commons, ARDC, and is supported by the National Collaborative Research Infrastructure, NCRIS. These 9 HSANDA nodes represent most states across Australia. As you can see there, we have the South Australian node. So I'm the project manager for SA, and there's also 2 specialised nodes, which are in cancer trials and the mental health node. Health Translation SA has been the driving force behind the SA node, and we all work together. Sharing of data from clinical trials is not a new concept. The global approach to clinical data sharing has been established overseas in countries such as the United States and the UK. National funders such as the NIH and the NRC overseas all have data sharing policies that evaluate and monitor their grant recipients, and they keep track of this, recording the sharing of data, and they use this to compete for new grants. In Australia, our national funder, the NHMRC, are reviewing their guidelines to align their data sharing policies and procedures with overseas activities. The NHMRC and MRFF are strongly encouraging data sharing here in Australia. In terms of future direction, national funders are moving towards mandating policies and procedures for data sharing and tracking outputs for future grants. HSANDA is driving the research culture change in Australia via the HDA platform. Ultimately, the aim is to make data sharing a standard clinical approach in Australia to align with data sharing activities already established overseas. There are many benefits and much value of data sharing and reuse, and this varies whether you're the primary researcher, a secondary researcher, a health service, a research participant, an organisation, or on a national scale. There's a lot of info on this slide, and this information is actually in our flyer, which is on the table at the back, so please feel free to collect one on the way out. So following on from the previous slide, I would like to highlight 3 main benefits of data sharing and reuse. Firstly, it's to make existing research more discoverable because we have a wealth of studies that are not accessible to others because people can't locate them. Secondly, it reduces duplication, so it avoids the collection of data twice and reduces research waste. For example, if you have unpublished data, this can also be shared and potentially used later on. And thirdly, it aids potential collaboration using your existing data to improve health outcomes. Therefore, to align with global clinical data sharing practices, we partnered up with ARDC to help design and build the Health Data Australia HDA platform. So HDA, this is how it looks like online, is a national online catalogue that was launched last year in July. This platform was designed for health and medical researchers to register a description of their research so it's easy to discover. Here's just a quick demonstration of how it works. So if a secondary researcher searches the platform, this is an example of the results that can be derived from that search. So pretty simple. If the secondary researcher is interested in accessing any of the clinical data output, they can click on Access the Data button, which you can see up there. And just to make it clear, the raw data is not stored in HDA. So it always remains with the data custodian, and the data custodian always has full control over what they do with their data. Once the data request has been initiated, this prompts a secondary researcher to fill out the data request form. They fill out the information across all the tabs that are on the screen. This eventually goes to the data custodian. They review the request and they make a decision whether they want to share their data or not. The HDA platform has a common framework for trialists to respond to data requests. It allows the data custodian and the secondary data user to track the progress of all requests in one place. The data provider, the data custodian can also apply their own specific governance policies. They can request further questions to the secondary data user, and they basically approve or reject the request. So how does it work? This is a flow chart that shows the steps of how a data provider uploads their clinical trial output on the HDA online portal. So the data provider needs to ensure that their registration is up to date in the ANZ CTR and that Section 11, the data sharing statement, is complete. This shows a willingness to share their data. So in order to, next step, in order to upload their data description on the HDA portal, they need to register their clinical outputs by entering a description of their study data set, and the description is called metadata. And to do this, they enter the information on a REDCap form. And for those people who don't know what REDCap is, in this situation, it's a database for managing surveys. I just want to make a mention that there is no identifiable data that is uploaded onto HDA portal, and also the data remains in the provider's control at all times, as I mentioned before. So once the REDCap form, the data has been entered on the REDCap form, it is combined with the ANZ CTR listing, and this is done by a contact person that the primary researcher is affiliated with, it can be the university or an organisation. They allocate a DOI, which is a unique identifier, and then this information is harvested into the HDA platform. Data users can then search and request access to individual participant level data, or they can request access to other outputs, for example, data dictionaries, protocols, statistical analysis plans, just to name a few. Data users can then search and request, then the workflow, is managed by each node around Australia. So here in South Australia, HTSA at SAHMRI will receive the initial request and then triage this to the data provider, and they review and approve or refuse the request. The data provider is responsible for reviewing the requests, and they give approval to the secondary researcher. So once the data provider has agreed to share the request, the data output then needs to be transferred via a secure and ethical way to this secondary data user. And that again is done by the nominated institute contact affiliated with the primary researcher. So I hope that the burning question on everyone's mind is, as a primary researcher, what is required to become a data provider and share the outputs of my research in Health Data Australia? The clinical trials that are eligible for inclusion in this platform are investigator-initiated, government-funded, interventional, observational, and any clinical trial that has ongoing recruitment or has completed recruitment. For completed studies, if there is no explicit participant consent for secondary use of data, primary researchers are still encouraged to share other outputs, like I mentioned before, data dictionaries, a protocol, statistical analysis plans. Where informed participant consent was not originally obtained, a waiver of consent could be considered through their local ethics committee, and this is if they're looking to request to share case level data. Again, we obviously encourage people in this situation for completed studies to contact their local ethics and RGOs for more information. Now, for currently active and prospective studies, what we're encouraging clinical researchers to do is to ensure that data sharing statements are included in their study protocols and participant information consent forms prior to commencement. This makes life so much easier if you already have signed informed consent for secondary data use from the get-go. That CTRQ developed the informed PICF template that contains data sharing wording. So basically, it's all there for you. You can literally copy and paste it and put it into your consent forms when you submit your ethics applications. We are so excited to be working with our LHNs, our local health networks at the moment, to promote and support data sharing statements for all new clinical study trial submissions. So watch this space. So data providers, we need you. The next stage of this program is about increasing engagement amongst clinical trialists. So we are asking primary researchers to become data providers, and this means that we are asking you to upload your data descriptions on the HDA portal, and we will help you to make this process as quick and as easy as possible. Just to sum this up, I'd like to say that there are so many benefits of becoming a data provider. It is so rewarding. You have increased recognition and visibility for your research. You can extend the life of your research by creating an opportunity to answer new research questions. You can meet your responsibilities to share data from publicly funded research projects and gain a competitive edge for new grants. You can encourage new collaborations to expand your research impact, not just here in Australia, but internationally. So there's so many benefits. I'd like to say thank you so much for listening to my presentation. And if you please contact us at the SA node to get you set up on the platform, to check governance and protocols, to check your trial registration. And if you have any other questions, please feel free to contact me. I would love a chat. Thank you.
No, I think we'll keep moving, but thank you so much, Nat. Look, there was lots of information there, but the message is Nat actually knows it inside and out. So please reach out and contact her, because we really need South Australians to embrace the opportunity that Cassandra represents. And I think that thing about getting data sharing words in your consent forms and getting it through ethics is the critical piece of the story. So yes, you can look backwards and get retrospective trials up and on, and their data dictionaries and things, but you also can do prospective trials, and that's where the secret is for the next 5 to 10 years, because it won't be too long and you're going to have to do this. It's not an option, you'll have to do it. They'll come down and say, for public money, you must share data. So get ahead of the curve, talk to Nat and get it happening. So thank you. Okay, we're moving on to our last talk. Here we go. Our lucky last speaker, and we're really pleased to have Dr. Karen Best is going to present today. Where is she gone? Oh, there she is. She's there. Sorry, Karen. You can see it's been waiting in the wings. All right. Okay. So Dr. Karen Best is the Principal Research Fellow on the co-led pregnancy and newborn health studies. She's going to speak to us today from Data to Impact, the journey of translating perinatal clinical trials into benefit for the community. And I really love this story and the practical application and some of the things you're going to tell us about, hopefully, which show that working in the real world. So welcome.
Thanks. Hi, everyone. Last session for today, we're nearly there. So yeah, it's a real pleasure to be here today and share a common interest of clinical trials with you all in the room. And I guess we all know the many reasons why we do clinical trials, and one of the fundamental aspects is to gather that quality evidence that can help us change practice and then result in improved outcomes for the community. So in the next 15-20 minutes or so, I'm just going to run over the past 2 decades of our research. Just give you an overview of how we've used the data that we've collected in clinical trials to actually turn that into a community initiative to try and prevent preterm birth. So why preterm birth? Well, preterm birth is the single greatest cause of death and disability in children under 5 years of age. Around 15 million babies each year worldwide are born preterm, and around 26,000 of these are born in Australia. We know that Aboriginal mothers have double the risk of preterm birth than non-Aboriginal mothers. And also, unfortunately, around 75% of preterm births occur spontaneously, and there are few interventions for prevention. One of the few treatments that has shown some promise, though, are omega-3 long-chain polyunsaturated fatty acids, and in particular, docosahexaenoic acid, or DHA, and eicosapentaenoic acid, or EPA. And these long-chain fats are most commonly found in fish and in fish oils. Now, the evidence for this dates back to around the 1990s, when observational studies in the Faroe Islands compared to the mainland of Denmark, and they looked at women from both of those populations. The Faroe Islanders have a high fish eating community. And what they found is that those women on the Faroe Islands had significantly longer gestations and had babies with higher birth weights. So that sort of led to the suggestion that a high omega-3 fat intake during pregnancy could actually have an impact on prolonging pregnancy. So now I'll take you to 2005, which is where our journey began in terms of prenatal studies and omega-3 supplementation. The first big trial we did in this space was the Domino trial, which stands for docosahexaenoic acid to optimize maternal and infant outcomes. This study wasn't specifically designed to look at preterm birth. Our outcomes were, we wanted to see if we could reduce the incidence of postnatal depression, And we also wanted to see if DHA during pregnancy could improve infant development. However, because of the observational evidence that was around and some other RCT evidence, we did include secondary outcomes that related to length of gestation and preterm birth. So the Domino trial was a national trial. We collaborated with 5 different hospitals around Australia to randomise almost 2,400 women to either an omega-3 group or a control group. In the omega-3 group, women were randomised to either 800 milligrams of DHA and 100 milligrams of EPA, or the control group had no omega-3 fats in. And women were enrolled from antenatal clinics from less than 20 weeks gestation, and they were asked to take supplements until their delivery. So what we saw with the Domino trial, unfortunately, we saw no significant difference in our postnatal depression scores, and that was using the Edinburgh Postnatal Depression Scale, so no difference between the omega-3 and the control group. And we also saw no difference in infant neurodevelopment. We used the Bailey scales of infant development to assess cognitive scores of children, and there was no difference between the omega-3 and control group. However, we did see significant reductions in early preterm birth, which the omega-3 group was just over half the risk of preterm birth than the control group. Around the same time that we were conducting the Domino trial, the first Cochrane review of marine oil in pregnancy was published by our group, led by Professor Macready's. This review included 6 trials and over 2,700 women, and it showed that supplementing women with omega-3 fats during pregnancy reduced the risk of early preterm birth by 31%. So you can see there's a bit of a trend happening with omega-3 supplementation and reductions in preterm birth. So now we jump to 2013. Within the time between the Domino trial and the ORIP trial, our group developed dried blood spot technology, which was led by Professor Gibson here in the omega-3 lab at SAHMRI. And that meant essentially we were able to collect blood samples from women anywhere in Australia to assess their fatty acid levels in their blood, which is a really valuable addition to this new trial called the ORIP trial. ORIP stands for omega-3 to reduce the incidence of preterm birth. It's the largest trial that's ever been done of omega-3 in pregnancy, and we randomised over 5,500 women. We included 6 hospitals around Australia, and women were again randomised to high omega-3 capsules containing 800 milligrams of DHA and 100 milligrams of EPA, the same as what we used in Domino, or the women in the control group received vegetable oil. The intervention was from enrolment until 34 weeks gestation, and this was the first time a trial was actually designed and powered appropriately to look at early preterm birth outcomes. And as I mentioned before, we had the valuable addition of blood samples, so we could actually see what women's fatty acid levels were at trial entry and at 34 weeks gestation. So when we analysed ORIP trial results, overall, we saw no difference in the risk of early preterm birth. However, in secondary analysis, when we actually looked at the blood results of the women with singleton pregnancies, we saw that women with low omega-3 status in early pregnancy were at higher risk of having a preterm birth, and that those women in the intervention group who received omega-3 supplementation actually reduced their risk by 77%, which is really quite substantial. On the other hand, we saw that women who entered the trial and already had a sufficient omega-3 level and then were given high-dose omega-3 supplements, they actually didn't need that extra omega-3, and some of those women, it could increase their risk of early preterm birth. So you almost have this Goldilocks effect where too much isn't good, and not enough isn't good. So while we were analysing all of the ORIP data before ORIP had been published, the second Cochrane review was published in 2018, and that was led by Professor Middleton in our group. And as you can see now, there's many more trials that have happened. There's many more women. There's over 20,000 women now included in this Cochrane review from over 70 countries. And again, this review showed that omega-3 supplementation in pregnancy reduced the risk of having a baby preterm, which is less than 37 weeks, by 11%, and reduced the risk of having a baby early preterm by 42%. So again, we're seeing that same consistency of reduced preterm birth. And interestingly, in the Cochrane review, a number of the trials in that review showed the same as what we had seen in ORIP, and that the effects of omega-3 on reducing preterm birth were greatest in those women who actually had low omega-3 status. So with all this mounting evidence, it's becoming clearer and clearer that a more of a precision approach is needed to omega-3 supplementation to reduce preterm birth. It's clear now, it was clear to us that women with low omega-3 status were at high risk of preterm birth, and that we could reduce that risk with omega-3 supplementation. And from the ORIP trial, we also saw that women with sufficient omega-3 status don't actually need additional high-dose omega-3. So this is what led to our thinking that preterm birth is best targeted with a precision approach rather than a one-size-fits-all and give everybody supplements. So based on all of this evidence, in 2020, the National Health and Medical Research Council pregnancy care guidelines were updated. They now include advice to pregnant women that supplementation with omega-3 long-chain polyunsaturated fatty acids may reduce their risk of preterm birth if they are low in omega-3. So that's great, we know that, but we have no way to identify who is low in omega-3. We know that diet isn't really an accurate predictor of someone's blood omega-3 status, and that a blood test is gold standard. So in 2021, to overcome this problem, we designed the Omega-3 Test and Treat program. The program is the implementation and evaluation of a statewide omega-3 test and treat initiative to reduce preterm birth in South Australia. So the main aims of the program are firstly to identify women with low omega-3 status in early pregnancy, and then provide them with evidence-based advice regarding supplementation depending on their result. Eventually, we will evaluate to see if embedding such a test in the community can have a difference on preterm birth rates in South Australia. So in the early days of the development of the omega-3 Test and Treat program, we underwent extensive stakeholder engagement with clinicians and pathology services and consumers, and it feels like many other people. There were a lot of people involved in those early days. It's a big jump from running a randomized control trial to starting a program trying to embed a new change to practice around the whole state. What we did learn from that early engagement was that a partnership with SA Pathology, we could actually leverage existing antenatal testing that was already happening in the community. By that, we added a test onto the SAMSAS test, which is the SA Maternal Serum Antenatal Screening Test done by SA Pathology, and that covers around 80% of women in early pregnancy having early pregnancy screening in South Australia. So this, by doing that, that enabled us to embed an omega-3 test and reporting of results into existing workflows. So we weren't reinventing the wheel from scratch. So how did we do this? It sounds quite simple. We just added a checkbox to the form, to the standard SAMSAS form that was already in use. That was the easy part, getting people to tick the box, not so easy. But this meant by adding the test, the checkbox to the standard form, it meant that a test could be ordered for women anywhere in South Australia, anytime less than 20 weeks gestation. There was no need for an additional blood test for the woman. There was no cost to the woman or to the health service. The omega-3 testing is done here at the SAHMRI lab because that's not offered by SA Pathology at the moment, but that's with joint oversight with both labs. So now, after doing this, we have a way to identify women with low omega-3 status, and then the usual reporting mechanisms, we can give advice based on those results. So this is just an example of the type of advice that we would provide back to a referring health professional, and that depends whether the woman's omega-3 status falls either in the low, the moderate, or the sufficient categories. We're trying to target those women in that low category, highlighted in the blue row, that are less than 3.7% total fatty acids in their serum. And they're the women who can reduce their risk of preterm birth if they supplement. So in terms of implementing this whole program, we adopted a multifaceted implementation strategy to try and increase awareness and adoption of the program around the state. We have digital and printed health professional brochures, as well as brochures targeted specifically to consumers. We've conducted a number of tailored education sessions and webinars. We're continuing to conduct those education sessions, a couple a week, going out to GP practices or visiting local health networks. We also have a dedicated web page. We've got educational videos and podcasts. We've developed culturally appropriate materials for Aboriginal women, as well as Aboriginal health services, to try and increase the uptake there. We're just starting our third wave of a mass media campaign. So you may see little snippets about the program on Channel 7, the replay one. And we're also on Metro and regional radio. And we have an ongoing digital marketing campaign. So there's lots of activity to try and keep the momentum going with the testing and make sure that both the women and their families know that the test is available, but also to let the health professionals know that it's there. So this is an example of where how we've gone progress to date. The columns represent the number of omega-3 tests that we receive each month, and we started from 0 in April 2021, and now on average we're receiving between 800 and 900 tests every month. We would like to see that increase. We're always trying to increase the uptake. We're reaching around 50% of women with singleton pregnancies in South Australia at the moment. And we've completed more than 22,000 omega-3 tests since we started in 2021. And importantly, of that 22,000, around 17% are testing low. And they're the women that if they receive that advice to supplement and act on the advice, they can reduce their risk of having a preterm baby. So we're looking forward to 2026, when we can analyse the preterm birth rates before the program, and see if we've actually made a difference with this community initiative. So it's been a long and rewarding journey from the Domino trial, which started in 2005. But every piece of data that we've collected along the way has played a crucial role, whether it's been in our own trials or in data from the trials that we've used in meta-analysis in the systematic reviews. It goes without saying that every study participant has played a critical role. We couldn't do what we do, obviously, without our study participants, but also the clinical trial members on the ground, the trial assistants, research nurses, clinical trial coordinators, project managers, we have numerous names for all of the roles we play every day, but shout out to everyone on the ground who's seeing the patients and participants and collecting the data. There are many important questions that remain. We'll continue with our implementation efforts, but we'll also continue to conduct more rigorous clinical trials to ensure that we can get the answers that we need and ensure the best outcomes for women and babies. I'd just like to acknowledge anyone that's been involved in any of the projects. I was a bit hesitant for acknowledgement slide in case I missed anyone, but all the steering committees and participating centres and our funders and supporters. And if you'd like more information, there's our website and contact details. So thanks, everyone.
Great presentation. Any burning question for Karen? Yes, Emma.
I'm sure we have the appropriate pathways, but have you looked at multiple births, or is there a safety trend, or?
So just repeat the question.
So Emma's asking if there's similar results for multiple births. So it's not a straightforward answer. So in the Domino trial, we excluded multiple births. In the ORIP trial, we included them, and they actually were one of the reasons why we didn't see effects, because they act differently. They have different outcomes. Multiple births have different outcomes than singleton births, and a lot of the studies in the reviews actually exclude multiple births altogether. So more research is needed specifically for women with multiple births, so we can work out what the testing should be, their levels should be specifically for that group. Good question.
Put your hands together for Karen. Fantastic. What a journey, hey? Oh, I was with you every step of the way. So thank you. I mean, I was feeling it when you're describing it all. I've only been with you on the last few years, but it's actually really interesting. And that whole thing about how do you actually get things to stick and how hard that is. Just guidelines isn't enough. Just things, it's actually so many stages. So I hope that's something you can take away with you, of something that really is important in that translation piece. So with that, we come to the end of our program for today in terms of presenters. There's been a lot of information shared with you, and for people online, I hope you've enjoyed it as well. Certainly starting with Stephen McDonald and the SWIFT trial and the ability to actually work with the Teletrials program and other things across the country to reach regional Australia. Then we had that fabulous demonstration from the nurse consultants around the state, from Mount Gambier, Jane from Mount Gambier, Emily from Berry, and Elise from Port Pirie. We thank them very much. Renee, great to hear about the work of AC Tech and also Compass SA. Obviously, that sticks with me. Remember it. So good job of connecting that name, and we look forward to how that evolves in the next 12 months. Great to hear about SAHMRI Clinical Trials platform and the opportunity that offers to all of you to actually tap into those wonderful resources and take advantage of that as much as possible. And then I'll give Natalie a plug for Hasanda and get your clinical trials ready for data sharing. Get those words into your into the documentation and have a look at what data you've already got that you could share now, along with other things. So please. And Karen, thanks again for that story. And it's fabulous to have that coming from South Australia. How proud we should be of that wonderful work that's going to influence things across the world. So to you, Maria, and the rest of the team, congratulations. So with that, I'd like to conclude today and just say thanks everybody for coming. Really, Spring into Clinical Trials is about all of us. And I think that was demonstrated today. So thank you. Enjoy. I think we've got probably a few nibbles left over, but I hope you enjoyed the lunch. So thanks for coming and look forward to working with you. Goodbye.